Good afternoon, almost. And our first speaker, we've changed the order a little bit, but John Galich is going to speak first on imaging options in ocular pathology.
Thank you. Congratulations, first of all, to the organizing committee for a great meeting, and thank you very much for the invitation to speak. I appreciate it. I'm a retina doc. I do retina surgery and medical retina, and Miguel asked me to talk a little bit about imaging with respect to pathology. So I titled my talk Optical Imaging of Ocular Pathology, and I've really focused, in the short time that I have, more so on vascular tumors of the retina and choroid, and a little bit of a historical retrospective as well as some of the newer modalities that we're starting to use. I have no financial disclosures for this talk. So just to refresh your memories on vascular tumors, we typically break them up into two subtypes, either retinal or choroidal lesions. Within the retinal group, we tend to focus on retinal capillary hemangiomas, cavernous hemangiomas, retinal vasoproliferative tumors, AVMs, such as in Wyburn-Mason syndrome. And on the choroidal side, we talk about choroidal hemangiomas for the most part, and whether they be circumscribed or diffuse. Most of these lesions tend to be congenital, acquired lesions. They're benign, very little malignancy noted within these groups. And the visual symptoms that they cause tend to be more secondary to their effects, causing, say, for instance, exudative retinal detachments, cystoid macular edema.
I can't see.
And oftentimes there's systemic association. So a lot of these are affiliated with neuroocular cutaneous syndromes. And I'll go into a little bit of detail about that. And treatment for these tumors are been pretty consistent through the group, and have included radiotherapy, cryotherapy, laser, and more recently the use of anti-VEGF in intravitreal injections, and at times there's a surgical need. So looking at the retinal vascular tumors, a lot of you are familiar with this, and I won't go into great detail, but we have retinal cavernous hemangiomas. This is that classic cluster of grapes type of tumor, which can be isolated and at other times associated with cavernous hemangiomas in other parts of the body, whether it be in the CNS or on the liver. Retinal capillary hemangiomas as well can be isolated, but we're more familiar with them with their association with von Hippel-Lindau syndrome, which is an autosomal dominant disorder. What we typically see, and more often, and more so, are retinal vasoproliferative tumors, and these are little pinkish, yellowish types of lesions typically found in the periphery, unbeknownst to the patient for the most part, and to a lot of physicians until they start behaving badly and start to bleed, and that's where they start to manifest themselves. And these have a high glial component, but for the most part are primary neoplasms. And as I mentioned, Wyburn-Mason with the AVMs, also within the neuroocular cutaneous syndrome, although there is no cutaneous aspect to this disorder. Within the choroid, we talk about choroidal hemangiomas, and again, these are subdivided into both circumscribed and diffuse choroidal hemangiomas. With the circumscribed, we see this as a smooth dome-shaped lesion for the most part, reddish-orange in color, which tend to be more in the posterior pole. And oftentimes we'll find associated findings such as subretinal fluid, exudation, but these tend to be mostly sporadic and not linked to any systemic disorders. As opposed to the diffuse form, where we often see this with disorders such as Sturge-Weber syndrome. And this is that classic description that all residents know and remember of the tomato ketchup fundus, which you can see down in the picture below, this diffuse uniform redness scattered throughout the posterior pole. So what have we been using up into the recent past? Well, this collection here of ancillary tests. We've used fundus photography, we've used angiography, whether it be with fluorescein or with indocyanine green, and we've used extensively ultrasound in pathology, both A's and B scans, and on a more comprehensive level, CT scans and MRIs to look at more associated disorders with these vascular tumors. So why do we do imaging? What's the basic purpose of doing all this imaging? Well, it's pretty simple. It's there to detect disease that we can't necessarily easily detect ourselves. It helps us with our differential diagnosis on these lesions. It provides a form of accurately measuring these lesions, and it also helps us follow the natural history of these lesions, whether it's progressing with time or whether it's starting to regress on its own. And if we do elect to treat these patients with whatever modality, it's an excellent way to note responsive treatment. So one that we're all very familiar with is fundus photography, and it's really a primarily an observational diagnosis tool. It's a two-dimensional color image, pretty much what we see when we're sitting at the slit lamp using a contact lens or a non-contact lens. And it's a very accessible test. It's non-invasive, and it provides excellent documentation. So when you can really get a nice, clear image of whatever you're looking at, in this case, Wyburn-Mason AVM, then it's a great way to follow with time to see if it's evolving in a better way or in a worse way. But some of the disadvantages of fundus photography, it's a pretty simplistic test, and it's limited for peripheral lesions. We, up until recently, haven't had good technology to really look out in the periphery of the fundus. And it has relatively limited quantifiable measurement tools. What's given us a little bit more in-depth analysis of some of these tumors is fluorescein angiography, and this is a dynamic test. As you know, with fluorescein, we inject this dye into the veins, and we excite that dye that's flowing through the blood vessels in the fundus using light, generally in the green spectrum, and this dye will fluoresce. And we can take wonderful pictures of the vasculature in the fundus, and it helps us confirm the diagnosis with whatever vascular lesion might be there. And it provides excellent ability to provide a differential diagnosis as well. So it's a dynamic test. It shows us activity of whatever lesion is there, and it's a great way to follow up patients as well. The disadvantages of this in the past has been identifying lesions out in the periphery, identifying choroidal lesions, which oftentimes are obscured by either blood or through the RP itself, and the wavelength that we use fluorescein angiography oftentimes doesn't have significant penetration deeper into the choroid. You do need trained staff to perform this test. You need nursing on hand to do the intravenous injection. And whenever you're injecting anything into somebody, bad things can happen, such as allergies and worst case scenarios, anaphylactic responses. But what is useful with fluorescein angiography is that it provides specific characteristics to specific diseases. And a few examples I've listed here, such as delayed flow with cavernous hemangiomas. It helps you identify better the feeder vessels that one sees with capillary hemangiomas. It can identify telangiectatic small vessels that we see with vasoproliferative tumors, which are very difficult to identify clinically, and at times it can help with classification. So here, just some simple examples of combination of fluorescein and fundus photography. Up top, we have the retinal cavernous hemangiomas, and as you can see on fluorescein angiography, very slow fill because of the relatively limited flow within these lesions. Below, we see Wyburn-Mason syndrome, AVMs, showing an extensive hyperfluorescence of these lesions with very little leakage. So as I mentioned, fluorescein is wonderful for retinal lesions, but when we look in the choroid, it's often difficult to appreciate things with fluorescein. So in the past, we've used indocyanine green, which you see here, and it's been useful in a variety of disorders, including tumors, to try and identify some of the unique characteristics of these lesions. For instance, with a circumscribed choroidal hemangioma, for instance, we have this typical washed out effect, which I'll show you with pictures in the following slide. But it does have some disadvantages. It's limited in its imaging too. As I mentioned before, you have a limited view with mostly posterior lesions. It's not really widely available to most clinics because of its cost for the most part. These vials are expensive. It costs about $120 to $150 each time you inject this dye into the patient, and the machinery itself and the cameras that are required are quite expensive. And similarly to fluorescein angiography, allergies are a concern. So with respect to circumscribed choroidal hemangiomas, this is a classic ICG, which shows this lacy pattern on early image capturing, a significant hyperfluorescence midway through the imaging cycle. And then because you have relatively good flow through these hemangiomas, the ICG clears out quite rapidly towards the end of the study, and you get this hypofluorescence, or what they refer to as the washout. Now, ultrasound has been significantly used in the past and continues to be used significantly at this present time, and it's still a very useful tool. You know, we measure tumor dimensions with our ultrasound. We can identify peripheral tumors, and this was one of the only ways we were able to really identify peripheral tumors in the past because of our limitations of the camera technology. It can find subtle things like subretinal fluid, but one of the more important characteristics is the fact that it provides the internal reflectivity internal reflectivity characteristics of lesions, which help us with our differential diagnoses. So if you look to your right there, we're all familiar with choroidal hemangiomas having a high internal reflectivity on ultrasound, which is represented here at the A scan, as opposed to choroidal melanoma, for instance, which has a relatively low to medium internal reflectivity. So a very useful test for some serious diseases and significantly different treatment modalities that would be required. Some of the disadvantages of ultrasound: you need a pretty skilled technician to perform these tests. And in addition to that, for very small tumors that are the size of millimeters, ultrasound doesn't really provide that level of sensitivity. As I mentioned with imaging studies such as CT and MRI, these are mostly to identify systemic associations with these vascular tumors. So in the case of Wyburn-Mason, we would be using it to look for intracranial AVMs, whereas with retinal capillary hemangiomas and von Hippel-Lindau, it's important to look at lesions that one might find, abdominal tumors such as renal cell carcinoma or pheochromocytomas, or hemangiomas in the cerebellum. Critical because, again, these can potentially be a fatal complication of these disorders. So what are some of the more recent tests that we're starting to use to look at vascular tumors? I've listed them here, and we'll try and go through these in the short time that we have. We're going to talk a little bit about wide-angle photography and angiography, some images you've seen in previous presentations. We'll talk a little bit about fundus autofluorescence, spectral domain OCT, enhanced depth imaging OCT, swept source OCT, en-face OCT, and a little bit about OCT angiography, which you'll hear later on in the day with Dr. Romero. So, as I said, we've seen a lot of wide-angle images throughout the day, and in retina we're starting to use this more and more. We use it for diabetic retinopathy. Anything that's out in the periphery we want to see, and we're starting to gain a greater appreciation for vascular abnormalities in retina with diabetic retinopathy, with things such as ROP or sickle cell. And it provides this panoramic view of the retina and thus the lesion if it exists out there. And the modalities that most of us are familiar with are the RetCam, the Optos, Optimap, and Spectralis. And these are all transpupillary devices. No special dyes are required, no special attachments are required to the eye. And they provide a variety of width with respect to the image. So with the RetCam, which is typically used in the pediatric population, we can get a view of 120 degrees. The Optos can provide a 200-degree field, and the Spectralis about 150 degrees. So as I said, with the RetCam, you can use that with babies, but the other two obviously need a little bit of cooperation to put your chin on the mount and to remain steady and fixed on the target. So really only available for the adult population. But what's also interesting is all of these wide-angle imaging systems do allow for fluorescein angiography. So you'd think, well, how am I going to do a fluorescein on a baby? Well, you can with the RetCam. And there have been studies that have looked, comparing the various types of systems, all of which are very good, and each have their own advantages and disadvantages and limitations. If you look on the left-hand side, we have our Spectralis, which shows a 150-degree field and shows nice shows nice detail of all the retinal vessels. And the Optos on the right side here, which shows an even greater expanse of the temporal and nasal fields. However, because it uses an ellipsoid mirror, we lose a little bit of the detail superiorly and inferiorly. As you can see up here, you lose the vasculature there. And on top of that, it can also distort some of the images that we find out there in the periphery. So they really have to be, if you have both machines, wonderful. It provides a nice comparative analysis, but I think most centers can only afford one. And you do have to take into account the limitations of that machine. So as I mentioned, these are non-contact imaging. We don't have to put a lens on the eye, and it's not really photography. We use SLO laser, which can use different wavelengths of laser. And the advantage is we're not using a bright light to illuminate the fundus, so it's more comfortable for photophobic patients. It can bypass a lot of media opacity, such as cataract. It provides great resolution, and it can provide both a detail of the macula and the periphery from one setting of imaging. And the other nice thing is it provides comparative software, so we can do serial images and compare and contrast over the course of the patient's evolution of treatment or of the disease process. So here's an example of a vascular tumor using wide field angiography. So in the top, we'll start over here in the top left. This is the spectralis. So it has a slightly smaller slightly smaller angle of image, up to 150 degrees. And in this case of a patient with retinal capillary hemangiomas from von Hippel-Lindau, we don't see all of the tumors. And these tumors can be very small. They can be small little red lesions, small little telangiectatic vessels, and can be easily missed on clinical exam. But with wide field angiography, if you position the patient properly, so in this case the patient was gazing down into inferotemporally, I should say, the lesions will light up. If you use the Optos system, which has a higher field, you can actually see these lesions with the patient using primary gaze. So here's another example of a patient with von Hippel-Lindau originally presenting with what was thought to be a single hemangioma in the retina, causing this exudative retinal detachment, which is outlined here with the arrowheads. But once they did wide field angiography on this patient, they realized, well, this wasn't the only troublemaker in town. There was actually multiple smaller hemangiomas that were also probably responsible for this exudative response. So each of these things were then appropriately treated with laser brachytherapy in this case, and resulted in resolution of the exudative retinal detachment and improvement of vision. As I mentioned before, vasoproliferative tumors are oftentimes difficult to see, obscured by blood, and wide field angiography offers a greater detail on what these lesions are doing, showing us some of the unique characteristics, such as the small telangiectatic vessels out here in the periphery. Again, these are oftentimes not found because they don't do anything. Patients are asymptomatic, and because of their peripheral positioning, really don't interfere with central vision. So I'm sure all of you have heard a lot about fundus autofluorescence. This is used with a lot of the SLO imaging machines out there, and it's a useful tool because it provides us a little bit of in vivo metabolic activity of the cells. And what it does is it's an autofluorescence of primarily lipofuscin. So the A2E that we find is the source of the fluorophore for autofluorescence. And these accumulate in RPE cells as outer segments of the photoreceptors are metabolized. So when you look at a typical autofluorescence picture here, it's black on the nerve because there are no RPE cells here. The vessels are black because they obscure the underlying RPE cells. And it's a darker here in the macula because of the pigment within the macula obscuring the RPE cells. But everywhere else you have a very uniform autofluorescent pattern. This patient down below here has a large area of geographic atrophy, so no RPE cells here, it's all dead, no lipofuscin. Yet the RPE cells surrounding it are sick and show a hyper-autofluorescence. So we typically use blue light. It's a blue light laser that stimulates the lipofuscin around 300 to 600. And the emission, although not very strong, is from the 400 to 800 nanometer range. So how do we use autofluorescence for tumors? Well, it's not really the tumor that's providing us useful information with autofluorescence. It's what that tumor is doing to the surrounding RPE cells that can give us some idea how this tumor is behaving. So you can see a very bright hyper-autofluorescence all the way down to a black hypo-autofluorescence based on what the tumor is doing. And when you look at pigmented tumors such as choroidal nevi, you'll see an overlying hypo-autofluorescence oftentimes because of a chronic atrophy of the RPE cells. Whereas with choroidal melanomas, which are a little bit more active, they're creating greater amounts of lipofuscin within the RPE, thus the orange pigment we all know about, and this acts as a fluorophore and giving you that brightness on the imaging. Choroidal metastases also behave in a similar manner, especially when there's subretinal fluid present and we see these fluorophores within the fluid itself. So how do we use it with circumscribed choroidal hemangiomas? Well, Shields group looked at about 34 patients and tried to characterize some of the autofluorescent features of these hemangiomas. And what they found here and what I've listed here are some of the features. So the tumor itself obviously is either iso or hypo, depending on the overlying RPE. Things such as the presence of orange pigmentation would be hyper-autofluorescent, and naturally RPE atrophy, hypo-autofluorescent. And these are findings that are similar as well within the diffuse choroidal hemangioma group as well. And this was pretty consistent across the entire group that they analyzed. So what about spectral domain OCT? This is a pretty ubiquitous machine. This is found in every ophthalmology clinic as well as every optometrist's clinic as well. And just, OCT has been with us now for, almost 25 years. It's a non-contact, non-invasive imaging technique looking at the different layers of the retina, and it does so by a low coherence interferometry. So we shine light into the retina. It reflects back at different intensities, and this is compared to and shone back to a reference screen. So we use the interference pattern to generate this artificial image of the retina. And these images have evolved quite a bit since their start. We began with time domain OCT, and we were really impressed by what we were seeing at that time. We saw the contour of the retina, we saw these gross pixelations here, and we thought this was the bee's knees, And at that time, you were only doing 400 A scans. It took a lot of time to acquire these images, and you had about 10 microns of resolution. But as time went on, you were able to do more A scans, higher density images. And as you can see with spectral domain OCT, we're requiring 50,000 A scan images with a resolution down to 5 to 7. And now we're starting to use laser light. So we're using a laser with a wavelength of about 800 nanometers to acquire these images. And now this has evolved even further with swept source OCT, where you can accumulate 200 to 400,000 images per second and acquire even greater resolution at a higher wavelength and a greater depth. So we've all seen these pictures. What are we trying to accomplish with OCT? We want to see it. We want to see the histology in vivo without having to take this eye out. And you see up top the histological cross-section of the retina from the nerve fiber layer down to the RPE, and down below a nice melange here of the histology and the OCT. Now you can see we're identifying layers of the retina. We're not really seeing it on a cellular level, but with time, this will, we hope, start to look like that. So how is spectral domain useful in vascular tumors? Well, it's really not that useful in the diagnosis of the tumor, and it's not that useful in the differentiation of the type of vascular tumor that it is. What it's useful for is monitoring the secondary effects of the tumor. So if that tumor is exudative in nature and causing subretinal fluid or cystoid macular edema or an epiretinal membrane, this is where spectral domain OCT is at its most useful. And it can also show us, again, another way of monitoring the effect of treatment on these eyes. So as I mentioned, it's really for detection, quantification of macular changes, a minor role in the differentiation of vascular tumors. But it has its limitations. You can penetrate about 1 millimeter with OCT, and this will exclude a lot of the types of tumors that we need to see, which are obviously thicker in nature. But for some of the retinal tumors, such as retinal cavernous hemangiomas, it shows some unique features. So here you have that little cluster of grapes here that we see on the color photo. On the IR, we appreciate it there. But what we see on the spectral domain OCT is it's an intraretinal lesion. It has an associated epiretinal membrane, which is common with these types of lesions. And there's a little bit of vitreomacular traction there as well. So it is useful. You probably know what that diagnosis is before you took a picture, but this gives you a little bit of additional detail on some of the more subtle features of it. So let's do a case. This is a case that was seen in the retina clinic. This is a patient, a 53-year-old male, came in with a 1-month history of reduced visual acuity, not too bad, down to 20/30, and on fundus exam was noted to have exudates, subretinal fluid, and a little further out was noted to have this reddish-orange lesion with a large feeder vessel in there, pretty characteristic for retinal capillary hemangioma. And this patient was healthy, didn't have any other systemic problems, no family members affected, so no real strong history for von Hippel-Lindau. And fluorescein angiography proved that this is a pretty vascular lesion, quite a lot of hyperfluorescence in the midphase. And OCT, when you look at the OCT down below, there's quite a bit of edema of the retina. As we approach the fovea, it doesn't look too bad, but the patient was probably having symptoms because now we get a little bit of thickening here in the fovea as well as a small foveal detachment. When you do an OCT over the lesion itself, it really doesn't provide you with much additional information. It shows you some significant shadowing beyond it. It shows you a nice vitreous attachment. The hyaloid is still attached to the lesion. And it shows you some pretty blurry looking CME, but not much on top of that. So this patient was treated with laser based on the fact that they were starting to have their central vision affected. Plus the other eye was amblyopic, so you don't want to wait too long in these patients to potentially compromise their better seeing eye. And after 15 minutes after the treatment was done, the patient said, "C'est flou," meaning my vision is blurry in this eye. Never a good thing to hear. And what they found was that this is an OCT in the fovea. So you remember before, the fovea wasn't really that significantly affected, but now it's affected. So there's a strong exudative response from treatment to this hemangioma. And as we go through the images, you'll see that there's quite a bit of edema in the retina. And 1 day later, this is his OCT in the fovea. So in addition to having CME, there's a lot of subretinal fluid as well that's migrated centrally. The vision is down. Patient's not happy naturally. And you can see here on this IR picture pretty much the extent of subretinal fluid that's there. So you can see here on fundus pictures afterward, this patient had exudation, now migrating towards the center, had subretinal fluid, and you can see some of the laser and some blood there at the area of the hemangioma. You can see the laser scars on it, around it, and that's not a happy tumor. So what did they do? Well, they gave it more laser, and they gave this patient PO steroids to try and reduce some of the inflammation, swelling, and exudation. And slowly but surely, it worked. So here's a great example of how OCT helps you follow the treatment of this patient over the course of several months, letting you know how aggressive to be with this patient, whether it be with additional steroids, injections, or laser in this case. How do we use it in choroidal hemangiomas? Well, it also has its limitations as well. As I said, you have a limited penetration with spectral domain OCT. It'll show some characteristic features of choroidal hemangioma, such as subretinal fluid. It'll show you the choriocapillaris, which oftentimes remains intact. But to try and measure the thickness, I think you'd have a hard time unless there was a relatively thin lesion. This is a picture from one of Dr. Singh's papers a few years ago, looking at a cavernous hemangioma, a peripapillary cavernous hemangioma. And I think clinically we could all diagnose this without the need of any type of ancillary tests. But what is helpful is that OCT can show you some of the multilobulated features of this lesion. But in addition, it'll show you if it's doing anything unpleasant, such as causing subretinal fluid adjacent to this lesion, which may migrate over here into the macula. So it does have its benefits. This is another endophytic peripapillary retinal hemangioma. This is another VHL patient. And again, OCT really doesn't provide much information on the lesion itself, but it does provide important information as to some of the negative effects of this lesion. So in this case, this patient was developing an exudative retinal detachment, which was migrating from this lesion into the macula and affecting the vision. This is the 1-year angiogram in this same patient after he received photodynamic therapy for this lesion. There's no subretinal fluid. There is a small amount of cystoid macular edema, but a much better picture compared to the 1 year previous. So now as OCT evolves, we're now talking about enhanced depth imaging, swept source, en face OCT. These are terms I'm sure you've all started to hear about. And as I mentioned, the standard OCT that we've been using up until now has been difficult to show us the resolution of the choroid based on the fact that light gets scattered. When it hits the RP or when it hits the choriocapillaris, light is scattered and penetration is compromised. So I'll talk about a couple of things, EDI and swept source OCT. EDI is essentially we're still using the same machine. We're using a spectral domain OCT, and Rick Spade and his group in New York City were clever enough to figure out that advancing the objective lens of the OCT a little bit deeper in the eye did two things. It inverted the image, but it also gave you increased clarity of the image in the choroid at the deeper layers. So you'd compromise the inner layers of the retina, but what you got in return was a better view of the choroid. And this was useful in starting to help us with measurements of the choroid that were greater than 1 millimeter. Swept source OCT, which is now starting to gain more and more traction, is using a longer wavelength of about 1,000 nanometers compared to standard or spectral domain, which is about 800. And it takes far more A and B scans of the image in a greater, larger range. So typically we get 3 by 3 millimeter scans or 6 by 6 millimeter scans in spectral domain, whereas now SWEP source can go up to 12 millimeters of a span of imaging. So you can imagine the amount of data that this generates. But both the better technology, our higher imaging speeds, better processing of all of this data, and one of the benefits is it provides a uniform image. So there is no compromise in the inner retinal layers. There is no compromise of the imaging of the vitreous. You get a clear image from vitreous right down to the sclera. And we'll look at a few pictures. So let's look at EDI. This is a spectral domain, like is found in many offices. And with EDI, without EDI, you see the nice layers of the retina. But when you incorporate EDI and push that objective lens a little deeper, you get a better imaging of the choroid. So now we see the entire choroid, not just the choriocapillaris, but we see Sattler's layer and Haller's layer as they start to get larger, right down to the level of the choroid. And using the calipers within the programs, you can actually measure the thickness of the choroid and subsequently any lesions that might exist there as well. SWEP source even better. It's a higher wavelength laser, deeper penetration, and again you see a greater definition of the choroidal vessels right down to the sclera. This is the sclera down here, and you can see the choriocapillaris, Sattler's layer, Haller's layer, things that we didn't see in the not too distant past. But what's even more impressive is we still beautifully see the inner retinal layers of the retina. And look at the definition of the vitreous. Before, vitreous we never thought about, but now with this imaging we can appreciate all aspects of the eye. So EDI with respect to choroidal hemangiomas, what does it show? It shows that nice smooth dome type of tumor that we're used to seeing. It shows us the preserved choriocapillaris oftentimes. It can sometimes show us a little bit of the subretinal fluid. And it also shows us to a certain degree some of the expansion of the choroidal vessels that we often see adjacent to these choroidal hemangiomas. In SWEP source, you see a similar image, except the definition is better. Again, we're using a higher wavelength laser, better penetration, and a little bit greater detail with respect to the choroidal vessels. And in this case, this patient had adjacent subretinal fluid, so you didn't have to compromise what you saw up here to get a better picture down here. This was all within one image itself. Now, to say SWEP source is only good for the choroid is not true. It's very good also for retinal lesions as well. In this case, a retinal cavernous hemangioma, which on normal spectral domain OCT is pretty blurred and doesn't really provide much definition, is a much different picture when one uses SWEP source. So, as you know, these are blood-filled saccules within these hemangiomas. These obscure light, they obscure lower wavelengths of light. But wavelengths closer to infrared can penetrate, and that's what we see down here. We see the saccules. We also see posterior hyaloid still attached to that lesion, and these are indicated by the red and blue arrowheads here. And using the calipers within the program, we can measure these saccules. Again, useful to see if this is progressing in the future. On-fast OCT uses SWEP source as well. So what is on-fast? We've used on-fast in the retina and with the spectral domain OCT, primarily looking at retinal lesions. And what on-fast is essentially what it describes. It's a coronal view of the retina, and it does it at different layers. So we're taking slices, starting at the ILM and moving our way down. And that was something you could do with spectral domain with certain machines of spectral domain OCT, but not so much of choroidal lesions. Within the choroid, though, now that we have SWEP source, we're able to do the same thing, but even deeper within the eye. So we see better resolution at greater depths and a better comprehensive assessment of the lesion structure. So this is a choroidal hemangioma using on-fast SWEP source OCT. And this is an interesting paper by Flores and Moreno. They looked at, I can't remember, about 15 of these images. They had independent observers look at this and trying to characterize what they saw on fast imaging with these hemangiomas. And they were 90% of the time they found similar characteristics. They saw the multilobular pattern, the honeycomb pattern. It was hyporeflective, confluent areas, probably suggestive of the lumen. The walls would be hyperreflective. And they were pretty consistent across their assessment. And the question, like we saw earlier, about the cross-sectional OCT maybe not mimicking, but representing the histology we also see with en-face imaging. And so if you look at this choroidal hemangioma on H&E stain, we're hoping that one day we'll see that as we get better and better resolution with en-face swept source. So we see these large cavernous vascular channels and the thin intervascular fibrous septa. All of this in vivo, no biopsy required. I'll skip over that. And the last point I'll make is OCT angiography, which we'll hear in a little bit more detail with Dr. Moreno. This is one of the newer non-invasive imaging techniques, and in retina, this is the buzz, and this is the buzz because people are looking at this for diseases such as AMD and diabetic retinopathy. And what this does, it employs motion contrast imaging to high-resolution volumetric blood flow information. So what this is doing is it's taking hundreds of thousands of A and B scans at a single point and comparing them. And what they're comparing is, whether the erythrocyte is there. So they do this, and they do this right across the board, and they can map the movement of this erythrocyte. So it's really a flow study, almost like a Doppler. It's a flow study using swept source OCT. And it's quite impressive because, A, it doesn't require any dye. You can do volumetric reconstruction because, again, you can do various slices of it. The only problem is it's limited in its size, usually about 3 by 3 millimeters, because of the vast amount of data. And it's unlike fluorescein angiography, you can't detect leakage. It detects flow, but it doesn't detect a leakage. So this is a typical OCT angiography. Here we're starting pretty superficially towards...
Miguel asked if you could please go quick.
Yeah, this is my last one.
Lunch interval, I'm sorry.
Sorry. This will be the last slide. So we see here the retinal vessels. We see the inner capillary plexus. As we move down, we see the deeper capillary plexus at the bipolar cell layer. And then as we get further down, we get no signal because there are no blood vessels there until we get down to the choriocapillaris. And as I mentioned, in retina, and especially in AMD, it's a great way of defining the choroidal neovascular membranes. So we still don't see very much of it with respect to vascular tumors, but that's not far down the road. So to summarize, we've seen a lot of progress in the management of patients with vascular tumor in the past decades. Present and future treatment modalities will closely be linked to the development of newer and newer technology. And this technology will be helpful in earlier detection of secondary complications, which will assist us in earlier intervention for these patients. I thank you very much for your attention.
I think what we can do is to perhaps withhold questions until after the session, just so that we stay moderately on time. Thank you very much. That was awfully good.
My pleasure. I'm going to have to do a judging for posters up the street at McGill, so I won't be able to answer any questions, but I thank you again for your attention.
Okay, thank you very much. Next speaker is going to be Natalia Villa, talking about intravitreal ocliplasmin, our clinical experience.
Hi, good morning, good afternoon, everyone. First of all, I would like to thank the opportunity of being here today. I'm from Barcelona. I've been here for 3 years. My first year was at the lab, and it was such a great opportunity. And currently, I'm a second-year retina fellow. So I will present a project that we did in conjunction with the lab and the retina department. So first of all, just to review the concept of vitreomacular adhesion syndrome, and then our experience with, our experience with ocliplasmin, that it's a new medication. So as a reminder, we know that vitreous is a gel-like structure that it's attached to the retina. With time, that can have some changes, can liquefy, and can separate it from the retina, creating a posterior vitreous detachment. We can document that pretty nicely with the OCT. So we can see that we have different stages of this posterior vitreous detachment. When we don't have an incomplete posterior, when we don't have a complete posterior vitreous detachment, we can see that we have some adhesions. So when we have this incomplete PVD and we have strong adhesion with the retina, it's when we can have vitreomacular adhesion, vitreomacular traction, and even if that progresses, we can have a macro hole. So that's a whole spectrum of these vitreoretinal interface disorders. so far, the treatment that we had for that and the gold standard was surgery. When we had a macular hole, so we perform a vitrectomy to detach that hyaloid, do ILM peeling, and that was what it allowed the macular hole to close. And when we had early stages of with vitreomacular traction, we know that some of them can progress, and the treatment for that was also surgery. However, recently in 2013, that was a new medication. It's a recombinant form of plasmin that can create this posterior vitreous detachment. We can see here the molecule that it's cleaving this space and separating the laminin, fibronectin, and collagen from that adhesion, creating a posterior vitreous detachment. So that medication was approved in Canada in 2013. Here at our institution was available for the first time in December 2013. So we were able to try this medication. We have the results of the main multicentrical trials with this the ocriplasmin, and they prove that this medication can create a posterior vitreous detachment and it can close a macular hole. The results we had from the trial were related with a clinical study. So what is also important is the real-world data, and there are several papers that have been published and reported different results. So that's why we decided to do our study and look at our results. So the purpose of our study was to look at the structural and functional results in patients treated with intravitreal ocriplasmin for symptomatic vitreomacular adhesion. It's a single-center prospective study. We included patients since December 2013, June 2015, and we perform an OCT pre-injection and post-injection at 1 week and at 1 month. We included patients over 18 years old with diagnosis documented by OCT of symptomatic vitreomacular traction, vitreomacular adhesion, VMTs, and macular holes, and phakic and pseudophakics, and patients that receive 1 injection of ocriplasmin. So we included 32 eyes, 17 were VMTs, 15 were macular holes. And if we look at overall results, we find that 54% we could document the posterior vitreous detachment, so the VMA was released. But if we look with different criteria, meaning that look at the patients that had the positive predictive criteria for this medication to work, under 65 years old, phakic patients without epiretinal membranes and adhesion that less than 1,500 microns, we find that the results are better. 77% of the patients detach it. If we look at that separately, the VMTs, we see that the traction was released in 40% of the patients, and about 30% of the macular holes close after being injected. But we need to define exactly what is success and what's a failure. So we define that the medication didn't work, so it's a therapeutic failure when we do not have the posterior vitreous detachment. But we can see that we have different clinical results, meaning that when we look at the VMTs, we have the ones that released, and we have the ones that did not release. However, we also have this group that had an incomplete release, and it's an interesting group because all these patients improve vision, even if the medication actually is considered didn't work. When we look at the macular holes, we also have the ones that the vitreous was released and the ones that did not release. In both groups, we have patients that closed and patients that the macular hole didn't close. And also here, we have an interesting group, meaning that the hyaloid was not detached, and 2 patients, the macular hole closed. So if we look at the visual acuity, so we have here on the right, if we look at the VMT patients, that's a pre-injection visual acuity in LogMAR, and if we compare with the patients that detach and release the VMT, we see that there is the visual acuity improve. But here on that column, we also see the patients that did not release, and we also see that the visual acuity improve. That's because we have this group that we consider therapeutic failure because it didn't detach completely, but they improve vision, and that's why this group also improved vision. If we look at the macular holes, it's a different story. So we have pre-injection visual acuity. When the macular hole closed, there is an improvement of visual acuity. However, when they did not close, they do worse. So here we see that the vision get worse after being injected. If we compare our results with the MIVI trial, we see that our patients detached in less than 7 days, most of them, and it was 64% of the patient, and that's similar to the study. And here we look at different structural changes in OCT. What we found is basically post-injection, we found one patient that had ISOS disruption. Cystic cavities were present, most of them pre-injection, but 84% presented post-injection too. And hyperreflective subretinal lucency, we can see that was present here in the first week. And when we look at the second OCT, that it's 1 month after the injection, 21% already decreased, so it gets very fast. We also measure different parameters in the macular hole patients. What it was interesting here, we also look at the whole form factor that you can see here, the measurements. And it's known that when we have that index, that it's more than 0.9, it can have an 80% of anatomical success. So we look at these parameters and we compare this with macular holes that fail and the macular holes that close. So we see that the ones that they close, they had over 0.9 that correlates with the surgical results too. Finally, the patients that they didn't work, the medication didn't work in macular holes, it was important to decide to do surgery. So we also have the results post-vitrectomy. So 35% of the 35% of the patient needed vitrectomy post-injection. Most of them were for macular holes, and 100% of the macular holes closed, and also the VMT that we did, it worked, the vitrectomy. So here we can see that there is an example of the patient that was injected, it was released, but the macular hole didn't close. Sorry, that's moving, I'm not doing anything, so it just, okay. So we see when that was a typical case of macular hole when the medication didn't work. And we see that in 80% of our patients, when they fail, the macular hole was enlarged. So we perform vitrectomy, and that's the OCT post-vitrectomy. We look at the ocular adverse events. Most of them are related with the PVD itself, photopsias, floaters, dyschromatopsia. And we also had one patient with ERG changes. We decide to look at the patients that were having surgery. That means that we had the patients that the oculoplasmin didn't work, and these ones were undergoing surgery. So we collect these vitreous samples, and that was our study group. We are still collecting patients, but we already have some results. We had 4 macular holes, and then we have control group that were patients with macular hole or VMT that the first treatment was surgery. So we look at different inflammatory cytokines and metalloproteinases, and that's only preliminary results, and we can see that we can find differences with the patients that failed Forgetria and the patient, our control group. It's interesting to look at that with these matrix proteinases. They can play a role in all this cascade and all this process of the posterior vitreous detachment, and we can see that there are differences between these groups. So in conclusion, we can say that our results were close to the real-world data that has been published so far. When we have a VMT and we have what we call the therapeutic failure, it doesn't mean that we have a functional failure. That means that this patient, even if they have an incomplete release, the vision can get better. When we look at the macular holes, it's a different story. So if they have therapeutic failure, the vision can get worse, and these patients need a prompt vitrectomy. when we do vitrectomy, post-injection is effective structurally and functionally. And one of the parameters that we identify on the OCT, the whole form factor, could be a predictor for anatomical success for these patients. The ocular adverse events that we found were common, but most of them were reversible.
Yeah.
So now we have this current therapeutic dilemma with these patients. So I think after looking at our results, maybe we were more conservative when we have to indicate oculoplasmin, but still we have these options with these patients to decide if we observe, if we treat with oculoplasmin, or if we want to do surgery. Thank you. That's all.
Thank you very much, and we have time for perhaps a question. Very nice presentation. If no questions, I don't see any hands. We'll move on to Lisa Diagon, OCT features that may predict conversion to wet AMD.
So my name is Lisa Jagan. I'm a first-year resident in ophthalmology at Queen's University. It's my first biopsy meeting. So I'll be presenting a research project I've been working on. It's called an analysis of spectral domain OCT features that may influence conversion to neovascular AMD. We've talked a lot about OCT, so we know that it has really revolutionized our ability to non-invasively image structures of the eye in vivo. This has played a huge role in monitoring patients with AMD. In particular, we're able to detect wet or neovascular AMD much earlier than we had been able to in the past. And we know the earlier that we can intervene with treatment, the better outcomes that we'll be able to see in those patients. The purpose of the study was to evaluate a subset of OCT features, which I'll get to in the next few slides, that may predict progression from dry to wet AMD in a 12-month time frame. This was a retrospective cohort study. It involved reviewing the medical charts of patients from a single retina clinic at the hospital in Kingston, Queen's University. And an important part of the patient population that we included in our study to pay attention to is that these patients had wet AMD in one eye and dry AMD in the other eye. And that plays an important role in our ability to have followed up on these patients because they were being seen and being treated for wet AMD. The eye of interest to us was the dry AMD eye. That's the one that we were looking at the OCT image for, and that's the eye that we looked at to see whether there was conversion to wet AMD at the 12-month mark. Exclusion criteria were pretty typical: any sort of confounding ocular condition, any previous treatment with anti-VEGF or photodynamic therapy. These are pictures from some of the patients in the study. We looked at vitreomacular adhesion, epiretinal membrane, drusenoid PEDs, and retinal pigment epithelial sawtoothing. We also recorded the central retinal thickness from the baseline images. This slide is essentially showing the fact that because these patients had wet AMD in the contralateral eye, there were several checkpoints from the time that we first looked at the OCT image in the dry AMD eye to the 12-month time frame where we could have picked up whether that eye had converted to wet AMD. And this allowed for some consistency in our ability to monitor these patients, even though it was a retrospective case or a retrospective study where we usually don't have that ability. Broadly speaking, we're looking at the patients who converted and the patients who did not convert to wet AMD, what was different between them. There were 232 patients overall that were included. The mean age was 78.4 years. Overall, 13.4% converted to wet AMD by the end of the study. And the only interesting or the only feature that really came out was that there was a statistically significant difference in the mean central retinal thickness in the patients that converted compared to the patients that did not convert. And it was, a matter of 20 to 30 micrometers, so 276.39 in the group that converted compared to 257 in the group that did not convert. When we plugged those same variables into a multivariable regression equation, the same pattern came through, which was that central retinal thickness was statistically significant in predicting who had went on to convert to wet AMD in the 12-month time frame. This is a nice graph, I think, because it just shows that the scale at the bottom is sort of off, but what you should see is where that purple line is extending from is that at 265 micrometers is where there's this switch where much more higher proportion of patients are converting to wet AMD. So approximately 3 times more patients converted once they were over the 265 micrometers for their baseline central retinal thickness. It's hard to say why this is. It may be that a thicker retina at baseline means more sequestration of pro-inflammatory or growth factors that can lead to conversion. It could be that that thicker retina is a sort of sub-threshold morphologic state before we're actually able to pick up frank cystic fluid, for example, with wet AMD. There are other studies that have sort of highlighted the importance of central retinal thickness. One study published in Ophthalmology in 2014 showed that when central retinal thickness is reduced early in the course of treatment with anti-VEGF compared to the same absolute value reduction in central retinal thickness maybe a little bit later on in the treatment, that you still get much better visual outcomes when you get that central retinal thickness down earlier on. So there may be something here that we can look further into. Overall, I think the strength of this study, there's always limitations when you're doing a retrospective study, but we used some very well-defined OCT features, and using the population that we had with wet AMD in one eye and dry AMD in the other, we're studying a fairly homogeneous group. They got frequent assessments, which gave consistency to our study, and they're a readily targetable group in our practice, so there's some external validity to what we have found from our study. In terms of limitations, we weren't able to do a full Drusen analysis, which we would have liked to do, the area, the volume. It would be interesting and I think important to know how that ties into the central retinal thickness values. And obviously, we always want to do larger, bigger, better prospective studies. And thank you so much for inviting me here.
Thank you, Lisa. And he'll come up and speak to us shortly on optical coherence tomography angiography. And whenever he gets settled, we'll get started. Thanks.
I'd like to thank Professor Bernier for the opportunity of being in here. We'll speak about him in a few seconds, but I'd like to thank him to start off with. So I'll be talking about a little bit deeper that John Gallick started about OCT angiography, and also some about the new OCT research developments. So before we had OCT, as John Gallick showed, we had several other technologies to evaluate the retina, including direct ophthalmoscopy, color fundus photograph, fluorescein angiography, and John already showed all the advantages and disadvantages, including ICG and so on. So the OCT was introduced, So OCT was introduced in 1991 by these two men, David Wang and James Fujimoto. And at that time, the idea was to create a technology to measure the thickness of the cornea. So they used a physics principle called the microinterferometer, and that technology was able to image the retina and cornea, retinal nerve fiber layer, and so on. Here, some of the images. This is the pattern of the OCT. This is the very first OCT prototype. This is the very first cornea image published in 1994, retina image in 95, retinal nerve fiber layer, and so on. These are the very first scanners that we had, OCT 1, 2, and 3. So until 2002, we only had one technology, and that technology was called time domain. And after that, in 2004, we had the possibility of using the technology that we have today, which is a spectral domain OCT. I'm not going to go into details of that because I don't want to, and John said a lot about that. I don't think I'll need to say anything else. But the greatest thing about OCT, or a spectral domain OCT, is the possibility of combining other technologies into OCT. And we know this, and it's so fantastic technology, and it has grown over the years that we can see that the number of publications surpassed the sum of all others ophthalmic imaging procedures in 2005, 2006. And we know that this technology, it's not only in ophthalmology now, but it's also in cardiology and ophthalmology, neurosurgery, dermatology, and so on. So it's a technology that's spread all over medicine and includes art. So people are using OCT in paintings to detect fraud. So they used OCT to detect fraud in paintings of Picasso and so on. So it's a technology, it's a really fantastic technology. So John talked today about enhanced depth imaging. It's a really fantastic technology. We started working on changing this full depth imaging into creating a greater scan. We wanted to scan the periphery of the retina at that time. So we were actually able to change the slab and to change the location and to increase the scan length. And that in 2010, we started doing at 13, almost 14 millimeter scans. Today, I'll show it to you, we're doing even further. So we're able to do that with the regular OCT, the current OCT that we have in the market. So he also mentioned about swept source OCT. The swept source OCT give us a very nice perspective looking at the vitreous image here. We can see a little bit of the vitreous, we can see the choroid, and we can see the retina all in one scan. But today I would like to introduce something new that we can do not with swept source, but with regular OCT. This is something called full depth imaging. So what is full depth imaging? I'm not going to go in how it works because I don't have time for that. So I'm just going to pass through some slides. So full depth imaging is the capability of scanning the vitreous, the interface, vitreoretinal interface, the retina, the choroid, and also the sclera in only one scan using the current technology that we have today. It's a modification that we're able to do it in Americana, and we're also able now to scan a 16 millimeter scan. So it's a really fantastic way of seeing this patient. So we can see it very nicely, the vitreous. We can see it in all of these patients. You'll see some other examples, and we don't lose details. We can still see the full depth imaging in details in each one of the layers of the retina. So it's a really fantastic way of assessing the patients. So, however, we're talking about something that we're only evaluating the macula. I want to ask you to pay attention to this slide because when you look to the retina here, you're only seeing one area of the retina. You're only seeing actually only the macula. So we're not scanning anything else. And we need to find a way to deliver accurate location or a correlation to the fundus landmarks. And with OCT until now, we weren't able to do that. So it was very difficult for us to understand areas of the retina without doing that. So we actually are able to start using a new technology that John already explained, which is unfast OCT, that carries a similar orientation to fundus photography. It's like ordering a fundus photography of the inner limiting membrane or the RPE and so on. So these technologies called unfast OCT. So we can scan layer by layer and choose the layer that we want to assess. So I'm going to give you an example. Here's the same patients. We have 4 presets. We can assess the inner limiting membrane, the inner plexiform, and the RPE and the choroid in only one scan. This is really fantastic, and just an example here. And that example we can see, if the patient has glaucoma, we can evaluate the retinal nerve fiber layer. And if the patient has a problem, we can even assess the epiretinal membrane. Or if we assess the RPE, we're able to locate the retinal detachment and also the RPE detachment in a much better fashion than the regular OCT. We actually combine forces with these men, and we're able to publish the book on OCT, on fast OCT. It's an atlas on fast OCT to overcome the situation. Why? Because our goal of understanding was using OCT to evaluate vascular diseases. So we had in mind that we would like to see this on OCT, these kind of modifications on OCT. So this technology today is the new leap in ophthalmology. It's the new technology. It's called OCT angiography. So how OCT angiography work? I'm not going to go into details. I'm not here to give details. But I want you to know that we're able to calculate the flow using OCT angiography in a much better fashion, better detail than the regular fluorescein angiography. So the methods, they compared repeated B scans, and the methods that it's mostly used all over the world, it's the method developed by David Huang and Yali Jai. It's called split spectrum amplitude decorrelation amplitude. I'm not going to go into that, but the most important information is that blood flow assessment is important because the greatest causes of irreversible blindness are associated with abnormal circulation at the optic nerve and macula, which is glaucoma, diabetic retinopathy, and macular degeneration. We cannot forget that fluorescein angiography is still the gold standard for clinical vascular evaluation of the retina and the choroid. So since the very first publication in 1961 by these two authors here, Novotny and Alves. So let me give you an example of how OCT angiography works. We have actually 4 capillary layers in the retina. So we have the peripapillary capillary network, we have the superficial, intermediate, and deep capillary layers of the retina, and we can assess it very nicely. And this is an example of a normal patient that you can see it in a very nice way. So here's both superficial and deep capillary plexus. You can appreciate both of them in one scan. So how about in patients with diseases? How about in patients with diabetic retinopathy, in AMD, or in ocular tumors, and so on? How do we see them? So to start off, I would like to show some practical cases of regular diseases that we see on an everyday basis. So one of them that is, so here's just an example of a neovascular membrane. We can see it in a very nice way. So in diabetic retinopathy, what do we see? So in this left slide, you can see OCT angiography, and this is fluorescein angiography. We're not going to see leakage. We're going to see something else. We're going to see flow. And the quality of the image, the detail, is way much better than we normally see in fluorescein angiography. However, what are the features that we see using OCT? What are the features that we see in diabetic retinopathy using OCT angiography? So we have several features that we are able to see. So microaneurysms, vascular loops, multiple capillary bedding, venous beating, non-perfusion, and enlargement of the fovea vascular zone. So just to give you an example of what we are able to see, here's an example of a diabetic retinopathy, a patient with diabetic retinopathy. We see the tortuosity, we see the microaneurysm, we see the narrowing of the capillary lumen, but we also can appreciate the non-perfusion area in this patient. And most important, we would like to differentiate which is IRMA and which is neovascularization. So we applied a simple, not a simple, but actually it's a simple way of doing it. We changed the location of the scans at this lab towards the vitreous, and we are able to see the neovascularization in this case, for instance. So we can see it very, very nicely. We can appreciate it in a much better fashion than in regular fluorescein angiography. So just to give an example, this is a patient that we only assessed the vitreous. We didn't assess anything else. We placed this lab inside of the vitreous so you can appreciate the neovascularization in this patient. So how about age-related macular degeneration? So what do we see? So this is just an example of a neovascular membrane. You can see the retinal detachment here. You can see the fluid, but you can't without OCT angiography. You can't see these kind of detail without OCT angiography. And much better, we can assess progression. So this is before aflibercept, 24 hours later, 7 days, 1 month, and 24 hours after the reinjection. So you can see the membrane shrinks once you inject the dye. So another example, this is what, when you scan a patient, this is what you're going to see. So you don't see a patient with neovascularization. This is the area that you want to assess. This is the chora capillaris. So you can see it much better. So another example, in MacTel, there's a lot of slides, so I'm going to run through them so you can have an idea what we're doing. So you can see the details on the current B-scan. Of course, we do the full depth imaging. That's why you have a very, very nice vitreous information in here. So here is what you see in the deep capillary plexus. You can see it very nicely, the vessels associated with MacTel. And how about it in glaucoma and optic neuropathy? What do we see? So the kind of details that we have in these patients are much better. So this is the UNFAS image. This is the OCT angiography image. And this is a patient of mine. So if we use the UNFAS, look at the Hoyt defect in here. With the UNFAS, you can see it much better than any other technology. If you use a regular OCT, it correlates very nicely. So you have a thinning in this area. If you use the ganglion cell complex to evaluate the size, the amount of ganglion cell loss in here, you can see it very nicely. But most important, when you use OCT angiography, we see the lack of capillary, and the capillary densities here is decreased in this case. So just to give you an idea, just to give you an example, this is a patient of mine that came to me, and she was complaining of decreased visual acuity, and we did the current, the established imaging that we normally do, color photography, fluorescein angiography, early and late phases, we're able to observe. And then we look at the superficial capillaries that we would normally see in the fluorescein angiography. And we didn't see anything wrong, both to the right eye and the left eye. But OCT angiography gives us the possibility of assessing other capillary layers. So what did we do? We went into the deep capillary plexus. So in the deep capillary plexus, this is what we found. It correlates very nicely. The patient complained of decreased visual acuity in the left eye, although the vision was 20/50. There was nothing else to understand about this patient. And we decided to go ahead and to do a further evaluation. And we noticed that there's a thinning in the OCT, in the inferior portion of the OCT. But most important, when you do microperimetry, we understood that she lost this area of vision. But we only saw there was a very meticulous kind of blockage, of vascular blockage, inside of the deep capillary layers. So one thing that it's really fantastic, that it's coming up, it's coming now, it's called angioanalytics. And what is angioanalytics? Again, no details, but it's the possibility of assessing quantitatively and numerically patients with capillary density decreased or increased and so on. So let me give you an example. So this is a patient, it's a small study that we had done. This is a normal patient, so we can numerically assess this patient. Normal patient, 20 patients in each category here. So normal, so this normal patient had a 55.5 capillary density in a 3x3 millimeter scan. So we decided to assess the mean superficial vessel density in a 3x3 scan in mild, moderate, and severe non-proliferative diabetic retinopathy and proliferative diabetic retinopathy. And what do we see here? As vessel density decreases, disease progresses. So you see numerically, we do have a number here, 55 compared to 36. And look at the lack of capillaries in the posterior pole and the macula. It's really, really great. So going over into ocular oncology. So thanks to my brother, Rubens Belfour, now president of the Pan American Ocular Oncology Society, were able to see some interesting cases of ocular oncology. So this is a patient that he referred to us to take a look at it. He already knew the diagnosis. So he said, Andre, can you assess this patient? Can you tell me what can you see in this case? So we decided to scan this patient. Sorry, I'm actually. So you can see a patient with VHL very nicely. You can see the details. And this is the unfast image. So what do we see? First of all, what do we see in the full depth imaging? We see the vitreous very nice. We see an epiretinal membrane and we see some vascular details in here. We can see some vascular maybe exudates or something like this in this area. So the quality of the image was very nice. But most important, non-fast, we see the epiretinal membrane affecting in a very bad way. So we decided to do. Instead of scanning the posterior pole, we decided to move the OCT all the way to the periphery here and assess this area with the OCT angiography. So here is the area that we assessed. So we can appreciate these vascular changes in this case. Another example of melanocytoma of the optic nerve, there was a presentation here. And here's just another example. I'm going to run through some of the slides. I don't have much time. Here, a patient with the presumed choroidal hemangioma with a regular fluorescein angiography and color fullness photography. We decided to actually use the full depth imaging and 60 millimeter scan. We can see the vitreous. We can image that, and we can also appreciate the difference, the pixel density change in this area here. So we can really see some of the details and we can assess the choroid. We're also able to assess not only the retina, but we're now also applying this idea into cornea and the anterior segment and use the unfast technology in this location as well. So just to give you an example, here we're able to assess the limbo microenvironment using unfast OCT. We can appreciate the palisades of Vogt in these cases. So we can really see quality details using OCT, the things that we didn't imagine before, things that we never thought we could do it. So we applied exactly the same simple principle, and we used OCT angiography in the anterior segment. So what were we able to do it? We assessed the limbus. We can assess the limbus. Look at a case of pterygium. You can see the quality and the details in a patient with pterygium. And most interesting, we also decided to assess the sclera that we never thought that we could do it. So in the sclera, we can see the collagen fibers with the regular OCT, but we decided to use OCT angiography. We can assess the sclera with OCT angiography in a similar fashion. This is just an example of a patient with limbo stem cell deficiency. So you can see that the vessels invading the cornea here very nicely. So I have three more. So this is the book that we just published, a year and a half ago on OCT angiography and some of the details that we're talking in here. So I have 5 more slides. I'm going to show very fast some of the new research developments, some of the things that we're working on. One of the things that is very, very important is the ability of evaluating patients that can't fixate, have a hard time to fixate. So one of the new technologies called dual track or dual tracking. It's the ability of using the regular tracking and combining a technology called motion correction technology that was developed by Dr. James Fujimoto. That gives us the ability of decreasing, it's much faster, decreasing the saccades that we see in patients that don't fixate well. The higher rate of success is fantastic because it's combining these two approaches, so it's reliable and it's very accurate technology. That gives us this possibility. So what is this? Using or creating a 3-dimensional OCT angiography, and we can fly through the retina. We can see it. And most important, we can use this to do wide field OCT angiography. This is not my slide. This is from Dr. James Fujimoto, but it's a fantastic way. So we do believe that in the future, this will substitute the regular fluorescein angiography. So what is in the future? What we expect in the future? We do expect something interesting. In vivo labeling, the capability of seeing areas by doing a cellular phenotyping, using OCT angiography to evaluate the retina and area by area. Most important, using a technology called adaptive optics. It's combining and defining it and assessing layer by layer, but most important, to differentiate cones, different cones and rods that we have in the retina. So, for me, one of the greatest projects that Professor Bernier is in charge is the OCT and ocular pathology project, which is combining these both information, both of the histology information with OCT, but I'll let Professor Bernier to talk about this soon. So in conclusions, what we can see today, that these new strategies provide a much better overview of the whole area of the retina. So allowing distribution and identification of the microstructure information, focal changes, as well as the distribution throughout the scan that were not available on the current scans that we do it in the fovea. That's only allowing to locate only the macula. And with OCT angiography, you're not using dye anymore. It is really fantastic. If you compare it with fluorescein angiography taking 15 minutes, OCT angiography take about 2 to 3 seconds. We don't inject any dye. It's very fast. We can assess layer by layer, not only one layer of the retina, but we can assess all 4 layers of the retina, including the choroid. So it is really fantastic, very fast, and no risk associated with. And it's interesting, but we are not doing only structural information anymore. We're understanding a little bit of functional. You're studying the blood flow. So in conclusion, it will help us to understand the mechanisms of vascular retinal and choroidal disease, and we do believe that it's a new biomarker with high sensitivity and high specificity. I would like to thank Professor Miguel Bernier, I don't know if he's here, but for this opportunity here, and I'm open for questions. Thank you very much.
Thank you, Andre. That was a great introduction.